we're billing ourselves as next generation cardiology. Reason is we want to train the internal medicine residents and the cardiac fellows for what we feel is the next generation. And so it's very hard to change the people who are in practice now. That's very difficult. We don't expect that to happen. We expect to insert new knowledge with new people. And so it took 17 years to get 60% of cardiologists to give aspirin when someone had a heart attack. 17 years to get 60% of cardiologists to give one aspirin when someone had a heart attack. That's interesting. Why 17 years? Well, it turns out that the attrition rate, that's like the retirement rate, disability, whatever, for cardiology, is 6% per year. 6% times 17 is 102%. So basically, the 17 years is how long it takes to replace all cardiologists. So it's not that we train people to do something different. We can't expect that. I'm not sure why, but what we're doing is inserting new people with new knowledge. And so our goal here is to embrace new people with new knowledge as well as communicate that knowledge to everyone else. And so here we go. Next generation cardiology. Our case today is not really very mysterious, but what's interesting in terms of next generation cardiology is how you take care of somebody and the differences in care and what the results are in the difference in care. And so the mystery is, how do you take care of the patient? What's the best thing to do for the patient? Not for the doctor, but patient-centered. What's the best thing for the patient? So let's tackle this case and discuss that. So basically we have two patients that we're showing somewhat simultaneously. And they're two patients that were very similar. They entered the system, the medical system that is, at the same time. They had similar complaints. They were similar ages. And so let's talk a little bit about this. And so we have PB, who's a 45-year-old female. She's wife of someone in the military. And so she presented at the MacDill Clinic, which is a very beautiful center over at MacDill Air Force Base, and basically had an echo while she was there. She had some palpitations. That was her main complaint. So it's not unusual to get an echo. And we'll talk about that in a minute. And then we'll go over the other side, and we've got EB, who's a 48-year-old female, who basically presented to Memorial with some symptoms of dysuria and nausea, which she'd had for a couple weeks. She's in very good physical shape because she's a marathon runner. She's a fitness instructor, and she does a boot camp. She works in the healthcare field as an RN. And she did have some urinary symptoms, the dysuria, and that was about it. No cardiac symptoms at all. So we have these two young women who are running parallel lives in terms of their medical life. Entered the system in little different places, different pathways. And so one has an EKG that's normal. The other has a urinalysis because of her dysuria symptoms. She gets a CT of her abdomen, has a little ovarian cyst, which is not unusual, but they look up towards the heart, and this is not an infrequent finding, that you get some test of the abdomen and see something in the heart that you're not sure about. And so there's a question about a cardiac mass in the heart on this CT that was done in the abdomen with contrast. In the same case, the other patient with palpitations had an echocardiogram done at MacDill. Those echoes usually come to me, and this echo, the tech saw what was on the echo and thought it was a left atrial tumor and basically panicked. And instead of going the usual channel where they just leisurely send the echoes over once a week and I review them and make diagnoses and send them back, they basically she went up the chain of command at the local level, at the base in the clinic, and said, "Oh, it looks like a tumor. This is very frightening." and the patient wound up being sent by ambulance to Tampa General. The other patient wound up being sent to an outpatient clinic. And so patient transferred to Tampa General for further workup and management by cardiologist and cardiac radiologist. Patient was prescribed antibiotics for cystitis, advised to avoid strenuous activity for a while, follow up as an outpatient with a cardiologist. That turned out to be me. Any questions thus far? And we have Robert Carroll has just signed in. Hello, Bob. And we have Janet Olson who signed in. Hello, Janet. So the patient at Tampa General had no change in her symptoms or any new complaints. Well, she only went down Bayshore from one facility to another. Patient presented in our office here for a questionable cardiac tumor seen on the CT of the abdomen. Reported in more detail some shortness of breath, dizziness, lightheadedness since she'd been discharged. She had a urinary tract infection with denied any urinary symptoms now and seemed to be doing quite well. Had no serious cardiac symptoms, just a few that could be tipped if you pushed her a little bit on the shortness of breath, dizziness, lightheadedness. You can see how parallel these cases are. The past medical history, pretty much the same. Case 2 had an appendectomy, hysterectomy, and cholecystectomy in the past. There were no medications except case 2 was on the recent antibiotics for urinary tract infection, and no allergies, non-smoker, both in very good physical shape. Physical exams were totally normal on both patients. Case 1 alleged cardiac myxoma. No tumor plop was heard. Matter of fact, I've never heard a tumor plop. What to do next? And so we're going to get to Pooh here. Pooh, what do you think about? What would you do next on case 1 or case 2?
EKG echo we have. If we have the old echoes, we can see that kind of where it's located, size, any mitral valve involvement, and based on that, then further test.
So how about an EKG?
Yeah, EKG.
There's your EKG. What do you think about that? You want to tell us a little bit about this?
Sinus, rates around.
We got some funny P waves. They look a little bit upside down.
Something like ectopic.
Got some interference. Oh, you had some interference, but looks like it's better now. So we've got these upside down P waves that are either some kind of junctional rhythm or ectopic atrial rhythm to give upside down P waves. So the P wave axis is different. And then the QRSs look fine, and T waves look fine, everything else looks fine. I don't see anything else. So let's move on. Well, case 2 had an echocardiogram, and in case 2, this is our echo. Who would you like to remark on our echo?
2 to 3 centimeters.
We've got Christine Fancher has logged in. Hi, Christine. And so we've got this mass that's totally occupying the left atrium. See that it's like from septum to wall, the valve, the posterior wall. It totally fills what appears to be left atrium, and it's not homogeneous. There's like dropout of echoes over here, some dropout over in here. I have to mute Pooh because getting feedback from you, so I have to mute you, Pooh. And so, see this mass, left atrium. I don't see motion in this particular shot because it's just a snapshot, but there was very good motion. It was not going through the mitral valve. It was bopping around in the left atrium, and so fills the whole left atrium, a left atrial myxoma until proven otherwise. What to do next? Well, we did the echo. We got echoes on both of them. Both of them are supposed to have myxomas. We've got a CT option, CMR option, cardiac cath option, and then eventually surgical options. So in terms of trying to look at this again, let's go back to Pooh and I'll unmute her and we'll see if she can do better in terms of background noise. Pooh, you want to comment on what you would do next with either one or both patients?
We need more imaging. I'd get a CT and then maybe an MR after that if needed.
I think you've been hanging around me too long, Pooh, because you're falling right into the corporate culture here. So that's exactly what we would do in advanced cardiac imaging. So let's see what happened. And we've got a CT for you. Hang on, we'll bring that up. So we're looking at the patient's heart. Here's the left atrium, the chamber we have the greatest interest in. You can see the upper pulmonary veins, lower pulmonary veins, right and left. Left ventricle, right ventricle, interventricular sulcus anteriorly, the left anterior descending, dividing the two chambers. Left atrial appendage, pulmonary artery, aorta. Not much to be observed from the outside, so let's go inside and see what things look like. Well, actually, you can see this left atrium is full of something very dark. Let's go look at where we can actually sort of triangulate this. And so in terms of triangulation, we're looking at the left atrium in three different views. You can look up the left upper view, which is a sagittal, coronal view at the right upper side. See this massive tumor filling left ventricle. Again, looks a little bit ahomogeneous. Does have some contrast in it. You can see here that there seems to be a relationship with the fossa ovalis. You can see where it's not attached. This is the left atrial appendage up here, one of the pulmonary veins to the left. So certainly a massive tumor in the left atrium. Here's where it appears to be attached, whether that's a stalk or whether it's got some, this is like a pseudopod going there, but whatever it is, it appears to be very much attached near the fossa ovalis in the interatrial septum. Huge tumor. Everything else seems to be okay. I don't see any signs of the tumor on the right side. Beautiful pictures. We could actually take this and dissect the tumor out. You could pretend to be a surgeon and do a dissection and see how much you have to open the top of the atrium to get it out. And now we have some CMR images. Incidentally, the CT scan showed normal coronaries. There were normal coronaries. So that's important to know. So we've got the MRI image. You can always tell this one that it's an MRI. This is a dark blood. Notice that with dark blood, this tumor becomes light then. Dark blood study is usually for anatomy. Tumor is very light, Fills the entire left atrium. See some of the coronaries. That's black is the coronary. There's the right coronary. This is part of the LAD coming down this direction. You can see there's nothing in the right atrium. Coronary sinus, left ventricle. It's looking pretty good. Just looks like a huge left atrial tumor. You can watch it move around. Clearly see it's very difficult for blood to get around it in the left atrium, come into the left ventricle. It doesn't have a lot of motion to it. It just sort of rocks back and forth. Sometimes you see the ones that do a plopping around, swings through some of them swing through the mitral valve leaflets in the left ventricle, then swing back again. You can see that there's a lot of surface area, a lot of possibility of microemboli. Pieces might break off, or maybe platelets would clump. There's some bulging of the interatrial septum over here. I think that's a normal bulging of it. I think the tumor is sort of bulging, pushing, but not going across. This is a sagittal view showing the same thing. Back to PowerPoint. We're back to PowerPoint, and we're back to the two cases, comparing and contrasting. So case one, back to that case. That case was actually the patient is hospitalized because the echo tech said left atrial tumor. I've read about this. This is dangerous. So the patient is hospitalized. And now the debate started at Tampa General between the cardiologist and the cardiac radiologist. There are cardiology programs that take both cardiologists and radiologists. There's a program at Brigham that's a joint program where a radiologist can train and a cardiologist can train both in the fourth year. And so the radiologist becomes a cardiac radiologist, the cardiologist becomes a cardiologist advanced cardiac imaging person. And so with that, it turns out that one of the things you find out is that advanced cardiac imaging is actually 20% technical, 80% cardiac information and cardiac clinical knowledge. So 20%, the outer rim, would be technical. You can get that technical either by a lot of training or having a great tech that might bring 10% and you bring 10%, or the tech might bring 15% and you bring 5%, or you might bring 18% and the tech brings 2%. And you sort of learn together as you try to develop sequences in cardiac MRI and programs in cardiac CT. And a radiologist then is trained in the technical aspects, which is 20%. He has to pick up that 80%. It's very difficult to pick up that 80% clinical correlation in a year. It's easier for a cardiologist who already has the 80% under his belt to pick up the 20% in a year and also make up for it by the technical knowledge of perhaps a highly trained tech. So there got to be a debate at Tampa General between the cardiac radiologist and the cardiologist as to whether it was a thrombus or a left atrial myxoma. The thrombus would be characterized by, you would think, atrial fibrillation, perhaps mitral valve disease with mitral stenosis, or perhaps mitral insufficiency, big left atrium. There would be other concomitant characteristics to make you think about a thrombus. Thrombus would be adherent to an area, but not the interatrial septum. It would be coming out of a pulmonary vein. So it's much more complicated. It was much easier to decide things with just one person involved. That is the case 2, where you could see that there was some left ventricular hypertrophy. You could explain that away on that patient. There was no hypertension. So you'd say that she was an athlete. There's overlap between an athletic heart and left ventricular hypertrophy. There was a mass. There was some elevation of the right ventricular systolic pressure. Normally should be up to 35. Ejection fraction was normal. On the other side, there was this big debate going on about left atrial myxoma versus thrombus, which doesn't make any difference if you're going to do surgery anyway, because you just pop out whatever it is and find out what it is when it's on the table. And so they did a TEE in addition to the transthoracic echo that was done at McDill. Transthoracic echo was done at Tampa General. TEE, where again the debate continued to roar. Cardiac cath was deemed to be done at Tampa General, where you have to be very careful if you're going into the left ventricle, because you don't want to have this tumor plop into the left ventricle from the left atrium and you knock a piece off. You don't want your catheter to be pushed into the left atrium, which can happen, and then you snag a piece of the tumor. So I'm not sure if there's a lot to be gained from cardiac cath, especially since we can do the CT and look for normal coronaries. Seems like the CT gives more data, but it was deemed to do a cardiac cath, and then the cardiac radiologist deemed to do a CMR, as we had a CMR over here as well. And so we were comparing the two and comparing and contrasting both cases, which we'll come to at the end when we find out what's done. So let's move on. And so we've got, should they do a CTA? Well, case 1, they've already done a cardiac cath. Some people do PET scans to say, hey, maybe this is a different kind of tumor, and maybe it's a sarcoma or something, so there's tumor mets. Let's make sure they're not. So they'll do an FDG PET to see if they're metastasized. Sure, that would be a good thing to do if you suspect it's a sarcoma or a different kind of tumor. Mangiosarcoma, fibrosarcoma of some sort, very rare tumors, but to be considered in your diagnosis. Now we're coming to the point of consideration for surgery. So let's go back to one of our cardiology colleagues, and let's go back to Pooh, and I'm unmuting you. Pooh, what would you think in terms of surgery on either one or both of these cases?
Myxomas are usually benign tumors unless they're very symptomatic. The second lady was complaining of some symptoms. I don't know how bad they were. But if she's symptomatic, you can consider surgery.
So they are considered benign tumors, but they are malignant in the fact that, one, they can embolize and cause a massive stroke and death. 2, you can embolize into the coronary and cause an acute MI and possible death. 3, can embolize into the kidneys, can embolize peripherally into radial arteries, femoral arteries, many times present as a peripheral embolus. You take it out, you look at it, and you find it's a tumor, and then you go back and do an echo, and you find out what happened. Of course, with atrial fibrillation, frequently we have emboli too from the left atrium if there's a thrombus. And so the surgical approach was discussed, and we'll show you what the surgery was proposed and what happened. So case 1, traditional median sternotomy, anterior approach, cardio bypass, surgical removal, left atrial myxoma. You got to be very careful. You don't want any pieces to break off. You don't want anything to embolize. And so it's a carefully performed surgery. Patient then had a 10-day post-op care, mobilized, left the hospital, The other one was robotically assisted open heart surgery. Lady would have a tiny scar on the right side and some little holes that were made in the sternum area to the right of the sternum, and to make possible to put robotic arms in, take off or at least open the hatch at the top of the left atrium, and then take the tumor out through the large incision on the right side, and then cardiopulmonary bypass for the groin. And it's very interesting because on the third day, the patient left the hospital and went across the street to the Marriott. Doctors made rounds in the Marriott for a day or two. The patient went home. Both patients recovered dramatically in terms of, having gone through major surgery. However, after 10 days in the hospital for diagnosis and 10 days in the hospital post-operatively, patient 1 came in the office in a wheelchair, barely mobile, and started cardiac rehab a month later. Patient 2 walked in the clinic, was doing fine. As a matter of fact, I saw her walking on the Bayshore before she came to the clinic. And I was on the Bayshore riding my bike and ran into her. I didn't literally run into her, but I saw her there and we talked a little bit. And so her recovery was much faster. And so we said, hey, she's doing so good, let's send her to rehab. So we're sending her to rehab a week after surgery. So I'd like to look at the two cases and compare and contrast. We have case 1, 20 days of hospitalization. Case 2, 3 days of hospitalization. Case 1, transesophageal echo, transthoracic echo. Case 2, transthoracic echo, 1 time. Case 1 was transthoracic echo 2 times, transesophageal echo. Case 1 was an MRI. Case 2 was an MRI. For me, an MRI is equivalent to a transesophageal echo. So transesophageal echo is somewhat invasive in that patient usually has Diprovan, which is moderate sedation, and the esophageal probe is inserted in the esophagus. Sometimes there's some trauma involved. Can be some bleeding involved. It's a minor invasive procedure, but invasive. Cardiac cath, of course, is invasive. Right and left, heart cath, measuring pressures, potential crossing the valve, potential knocking off a piece of tumor, certainly has some risk associated with it. Coronary CTA, I've never seen anybody have anything risky happen with coronary CTA, as far as my experience, in the patient selection that we have. And then 2 different surgeries. One was a mediastinal, traditional open heart surgery. The other was what I call next generation surgery, which was robotic surgery. Which the people who don't do it say it's a terrible thing. The people who do it says it's really easy. It depends on training, hand-eye coordination, ability to get the training that you need for that. People who do it apparently are very, very good. Some people try it, decide they don't like it, go back to mediastinal. It's a totally different kind of surgery. Seems like folks who are young who have done a lot of video games would be more adept at it, but we've had guys that in their 40s and 50s have adapted to it quite rapidly and really use all the knowledge they had from doing limited access surgery to doing robotic surgery and doing it quite well. So what are your thoughts? Which patient would you want to be? Why does this dichotomy exist? Why doesn't the system work where everyone gets the streamlined care? Who cares which way you go? What is the difference between an advanced imaging cardiologist and a cardiac radiologist? And so I'd like to ask the audience, what surgery would you like to have? Why is there a difference? Janet, would you like to make some comment? Janet Mora.
Yep, just once. Oh, there. Can you hear me?
I can hear you well.
Oh, super. Okay. Well, obviously, I think that the answer to that question is pretty easy. Everybody would like the less hospitalization and the shorter surgery. My questions were, you know, even if someone did not do robotic surgery, why could the patient not have had a different approach, maybe a parasternal approach or even a mini sternotomy, as opposed to, you know, or a minimally invasive procedure, as opposed to a full sternotomy, cardiopulmonary bypass? Do they really need to do it that way?
Yeah, that's a good question. And I guess for the most part, what's happened in terms of cardiac surgery is we've had the proliferation of so many surgical programs that the pie keeps getting smaller. The piece of pie keeps getting smaller and
Yes.
smaller. The pie gets larger, but the pieces are getting smaller. And so we wind up having a program where one or two surgeons might be there, and their experience is going to be 200 cases a year at the most. And so everyone becomes like a general contractor.
Right.
And so we don't have a mitral valve specialist, which we do, I think, in one of our hospitals. We have one in Blake, but for the most part, there's not a mitral valve specialist. There's not an aortic root specialist. And so it's really hard to get people that have the experience if you're doing 2 mitral valves a month as opposed to a mitral valve a day, or maybe 2 or 3 mitral valves a day. So the robotic surgeons are doing 2 to 3 mitral valve robotic surgeries a day, and so they feel pretty confident about that, whereas perhaps the cardiac surgeons in different institutions might be doing a minimal mitral valve repair once a month or twice a month, and they just don't have the opportunity. And so it's subtly changed from when I was at Tampa General, when there were 1,200 cases being done, and the surgeons would be having an active part in mitral valve repair, mitral valve surgery, aortic valve surgery, and so on and so forth. And so it certainly makes a difference, and it's hard to play catch-up when you have a limited surgeon. And that just doesn't mean just the surgeon. We're talking about the team. And the team's used to seeing downstream. They see all these aortic valves flowing down, and they know exactly what to do. They see all the mitral valves. And, of course, if you've got a lot of cases in the recovery area, then there's a lot more to do for people. And so you'll see the surgical team coming at 5 a.m. to make rounds on 10 people, you know, that had just had surgery, which means a more extensive approach, more to see, more to do, more to think about, more exposure, as opposed to if you got 1 or 2, you can come in any time, and it's no big deal to make rounds. It's not a big issue that you're going to see a lot of patients, pull a lot of tubes, and take a lot of patients down to the next recovery step. And so that seems to be the part. And so robotic surgery not being generally available everywhere, you have to send the patient there. And so you have to have a patient that's willing to go to a major robotic surgery center, and you have to be able to offer them that. A lot of people aren't going to offer them that because that's another hospital. That's not our hospital. And basically we're totally committed to the surgeons in our hospital. But it's really interesting because, you know, I'm at Memorial, so there is no surgical program here. And so we're not committed to the surgeons at our hospital. And so we give the patients the options. We say, where would you like to go? What would you like to do? You know, what kind of volume center would you like to go to? Some people say, well, I have a sister in New York. I would love to visit her. You know, do you have a high volume center in New York? We say, yeah, we have Didier LeMay at New York University, who's one of the world's best robotic surgeons. Or we say, you want to stay in the South? Yes. You know, well, we'd like to go to Greenville, North Carolina. Well, that's an easy one. Dr. Chitwood, who's retired now, was over there and was the #1 robotic surgery in the world, which was really interesting because I saw somebody from St. Joe had gone to Dr. Chitwood, one of my first encounters, maybe 15 years ago, and I said, Dr. Who? Who's this doctor in Greenville, North Carolina that people are sending patients to? That's bizarre. And so
they didn't know who Dr. Chitwood was?
I didn't know. 12 years ago, I did not know who Dr. Chitwood was.
Okay. Well, the only other question I had, Dr. Harrison, is that, you know, you were talking about, okay, you had your echo, you knew there was a mass, you thought it might likely be a myxoma, but what would be the distinction, or what information would you glean from the CT that you would not get from the MRI, or vice versa? Would you, it seems almost like you would get the CT and then, if indicated, get an MRI, and I'm just not clear on the information that you would get from either one of those studies to sort of narrow down your differential diagnosis.
That's a great question. And so it seems like here's what we're dealing with. We're dealing with frequently surgeons who've never accepted a patient for open heart surgery without a cardiac cath. And at the time, which was a couple years ago before we had the revised surgical indications for valve replacement, the surgical standards were cardiac cath. It did not say that they would accept MRI and cardiac CT in lieu of cardiac cath. Now we had Dr. Chitwood who was willing to do that. We had Dr. Badwar who said, no, it says right here in the guidelines cardiac cath. I see you got plenty of data. That's okay, but we're going to do a cardiac cath because it says right here in the guidelines patient must have a cardiac cath, which is conflictual, and the guidelines, are always behind. They don't update them online. You don't see changes occurring rapidly on guidelines. They're big committees that meet. And so basically to deal with that, we said, let's go for overkill. We're going to give you every non-invasive test we can do short of the TE. We skipped the TE. The MRI is equivalent to TE. So we said, we'll do a CT and an MRI and give you both, and maybe we could force you into skipping the cardiac cath as a surgeon and feeling more comfortable with doing that. And so Dr. Chitwood felt very comfortable with doing that, and we were able to get him to do that. We had several other surgeons who also, and then when the guideline changed, then we could get people to do that. I remember when we were sending patients to Dr. Chitwood for aortic valve replacement and with coronary CT with the coronaries and not doing a cardiac cath, and he was fine with that. He was much better when he got the results that came out of the Netherlands, where Dr. De Vader had a group of patients and Dr. Soyes had a group of patients that had cardiac CT without cardiac cath who had aortic stenosis, and it got replaced. And so he was much more comfortable when he saw that data, and there was some published large experience. And so not just logic. We can't go on logic. We're all afraid medical legally we're going to get sued. So everybody's running around trying to CYA. So I had to have overwhelming data from a non-invasive standpoint to show tumor from this modality, tumor from that modality, so that I can get them to go ahead and operate and find a surgeon that's amenable to doing that without having the cardiac cath. Make sense? Do we have any other questions? Dr. Carroll, do you have any questions about this?
This is John. I'm one of the residents at Bayonet Point. I had a question.
Hey, John. How are you?
Doing well, sir. Would anybody have the capability to do an endovascular attempt at this? The OBGYNs have a little thing called a morcellator. Is there any way you could enable some sort of device to take this thing out endovascularly?
That's for the next generation of next generation. This thing is so humongous, that we wouldn't attempt that. But, we can show you some other tumors. Hang on just a second, and we'll show you some other tumors that you might be considering in the future if you go that direction, how you could get these out. So hang on. We're going to get over to another computer and show you some other tumors. And so you can see that this is a lady that has a papillary fibroelastoma on the aortic valve, and so it's a much smaller tumor. If you're going to start somewhere, you might start on the right side of the heart because then embolization is not as serious. And if you were involved on the left side and you advanced your technique so that you could remove tumors endoscopically, and you were moving in from the right-sided stuff to the left side, this would be the one you would start with. Again, the fear of embolization is always there. This patient had a TIA. She then had a transesophageal echo. The transesophageal echo showed this, and the cardiologist said, no problem, don't worry about it. And so then her internist saw the information, and no problem, don't worry about it. And he thought that was somewhat cavalier on a young woman who's having TIAs. And so she had another TIA, and he sent her over to me, and we said, yeah, this is a problem, let's worry about it. And so this is one that required surgical approach to take it out. The surgery being more dependent on what else was there. And there was a mass over here, you can see, on the left-hand side, which is a paracardiac, para, P-A-R-A, not peri. It's outside of the pericardium, so it's a para, meaning next to, cardiac tumor that looks like what's called a cardiac cyst, sometimes called a paracardiac cyst, not peri, and sometimes called a clear water or still water cyst, because when you take it out, there's perfectly clear solution in there that looks like creek water that's from a spring, and sometimes called a spring water cyst. And so the approach in this particular patient was to take the fibroelastoma out, and at the same time go take this out because this was getting bigger. So, John, that might be if you start with after you've had experience on the right side of using tumors. And so you would build on that experience. And this is the smallest thing that we usually have. We have a smaller one. Let me show you a smaller one if you hold on, please. And so here we are on this gentleman who has this, see this little smudgy area on the interventricular septum? There's a little smudgy area there, a tiny little thing. That tiny little thing is moving back and forth during motion on the echocardiogram. And that tiny little thing is another papillary fibroelastoma that in itself is benign, but if pieces break off or if you get platelet clumps on it and they come off, they can go to the brain and cause a stroke, so that can be very, very serious. And so this would be another one if you were designing techniques and perfected them on the right side of the heart, you would be able to look at how you could protect with some kind of like parachute or something to keep that from embolizing at the same time that you would resect it. And so that was resected robotically with minimal access surgery in this gentleman prophylactically because of fear of embolization. We can show you right-sided tumors where you might start if you were doing procedures. Hang on just a second. So this is a very nice image down in the MRI. And this is where you would start if you're going to try endovascular resection. Because this is a patient who has a right atrial myxoma attached to the interatrial septum. And you can see it bouncing up and down with the blood flow. And so that would have embolization possibilities to the pulmonary arteries and pulmonary infarcts or pulmonary emboli. And so there would be much less risk of a severe complication. The most severe perhaps being pulmonary embolus or pulmonary infarct. However, if you're resecting that off of the septum, you've got to take a little button of the septum with you where the stalk is attached. And so, therefore, you have the risk of embolizing from right to left if you're involved in surgically removing that with a little button of the interatrial septum. And so, also, if you're going to do that, you're going to have to patch it with a little piece of pericardium. And so that makes it much more problematic surgery, much more involved than just flipping that off and sucking it out. we're always afraid of recurrence of the tumor, and so you got to take enough, certainly the base of it, the stalk. Sometimes it's sessile, and there'll be more than just the stalk. It'll be a wider sort of pathway where it's attached. So you got to make sure that you get it out so it doesn't recur. And so, so there are a lot of problems, but I'm not saying that we can't overcome those, because we certainly have overcome many other what seems more difficult, and mitral valve replacement percutaneously and the aortic valve replacement percutaneously. And so now we can end here. So basically, that's where we're going to end in showing some of these tumors. And so you've seen 2 patients with left atrial myxoma go 2 different pathways. One in the hospital costing a lot of money with cardiac cath. He just started having surgery, 20 days in the hospital, coming out in a wheelchair and coming to the office in a wheelchair, getting a cardiac rehab in a month. The other, what we call next generation cardiology, where we CT and MRI, a little bit of redundancy, of course. We didn't have to do the TEE, which is more invasive. We didn't have to do the cardiac cath, which is more invasive. And we did robotic surgery, where it's 3 days in the hospital and you're out of there. You have minimal scar. You can still wear your bikini. And so, and that patient walked into the office. And so certainly a difference in morbidity if it's done well. And then you had a chance to see some of the other tumors that we're involved with, 2 pathway fibroelastomas, as well as another myxoma that's in the right side of the heart in the right atrium. We've seen practically every kind of tumor that you can imagine, and this will be our last time touching tumors and talking about them. There's such a variety. Metastasis is probably the most common tumor that you'll see in the heart. And then primary tumors of the heart are extremely rare. The myxoma being the most common. The left atrial myxoma being the most common, and myxoma. So we'll be talking about this more and presenting more academic information as we go on. But the tumors do sometimes have systemic symptoms, and so patients bring that with them. They think they have some kind of vasculopathy because their sun rate's going to be up, and they have systemic symptoms, fevers, and so it does somehow cause probably some kind of immunological reaction giving the systemic symptoms. These patients have minimal symptoms, and we just stumbled into tumors. In the future, there will be people that we're looking for tumors, especially if they have embolization. That's when you go back and look for the tumors that embolize. So thank you very much. We're looking forward to changing this conference sometime in the future to a noon conference. We'll let you know. In the meantime, we're still going to be serving coffee Wednesday mornings. Thank you very much, everybody. Nice to meet you again. Bye-bye.
Bye. Thank you very much. It was a nice conference. I enjoyed it. Bye.
Thank you.